Thank you. Thank you very much. It's nice to be in front of an audience after all these years. So today I'm going to talk to you about ethical and responsible digital mental health innovations. So some of the essentials, there are many of those. First of all, I want to say that I'm going to talk a lot about the Accel Center, and my co-director, Isabelle Ouellette-Morin, and I have been working on this project for quite a few years. So I did not do this alone. All right. So what is the Accel Center? Well, the Accel Center is an accelerator of technological innovations in mental health, hosted at the Research Center of the University Institute in Mental Health in Montreal. And we aim to contribute to the development and validation of digital devices in mental health. And at the time that we thought about creating the Accel Center, we saw the emerging need to develop a hub where many stakeholders could interact together and go toward the same goal with the same minding. So, and this Accel Center, we aim two main objectives with regard to care, mental health care. First, it was to facilitate access to mental health care through digital devices. And also it was to improve the effectiveness of traditional approaches to care using digital technologies and AI. I think many of you saw the presentation of Alexandre Dumais, who is a researcher at the Research Center yesterday. This is a clear example of how we can innovate by adding some digital device to psychotherapy for schizophrenia. And our mission is to promote optimal and appropriate, and so meaning ethical and responsible integration of digital technologies in mental health care. Since the last 5 years, I realized that it would be almost unethical to integrate digital device, to not integrate digital device in mental health care, because so many of these became evidence-based with many published papers on either virtual reality that was there for quite a few years now, and also with regard to websites and telepsychotherapy, as my colleague Raymond told you earlier. He published a paper in 1986. I mean, it's been a while. And as you will see later on, I will talk to you about another study that I did in 2008. And it took the pandemic to get telepsychotherapy or telepsychiatry as a usual mean of care. So how do digital technologies contribute to mental health care? Well, mostly by counteracting stigmatization, which is a big barrier for people to access to care, a bigger barrier than the difficulty or the wait list that we see. People tend to self-stigmatize themselves, thinking that they will get better by themselves instead of going and to receive some and reach to resources. We will be able, with the DT, also to provide self-management tools, generate low-cost care, respond to regional needs, because, of course, we know that in rural areas, specialized treatments are not as accessible. We will also make evidence-based treatment accessible. This is quite some way also to get to the people who need those treatment directly through either internet or through a mobile app. So, and lastly, we will be able to act earlier with people. You may know that About 3/4 of mental health disorders develop before the age of 21 years old. These people are very techno-competent. They know how to run an app very easily. They don't care about doing psychotherapy through an iPad. So we may then prevent chronicity of mental disorders. So when we began to think about the Accel Center, it became evident that we needed to build an ecosystem. This is not something that we do in silos. We know we need to work together, and we did gather researchers as well as users, being clinicians or patients or citizens, because we need to reach those people who do not come to our services. And it's more than half of the people with mental disorders, at least in Quebec and Canada. But we also need to work, of course, with the industry. We need to work with the startups, with the big businesses who do also virtual reality, and because they have this expertise and they have also this agility to develop all these digital devices and make them, attractive, and also to favor engagement in them. So, but we also need to work with granting agencies, with ministries of health and social services. So we need to gather a lot of people around this topic if we want to accelerate the integration of digital technology in mental health care. This is why we launched the Accel Center in January 2018. At that point, you can see that we did gather a lot of people to engage them in that movement. I was glad that we did that before the pandemic, because at the time of the pandemic, then we could really reach to those people and make plan to, again, integrate more rapidly digital technologies in mental health care. We had many meetings with the Ministry of Health and Social Services before and just before and right after pandemia. And he needed our expertise to know what to do, because people could not reach out their services in hospitals like they did usually. In the meanwhile, during the pandemic, we also worked a lot on internal processes to accompany better our researchers in the development of tools, digital tools. And so we did this management support structure that we can support researchers from the early phases of ideation of their project through the technological design, the scientific validation, and as well as the promotion and the longevity planning of the tools, so that it can be sustainable for a long time, and with the best partners that we can find to act with them. And when we talk about digital technologies, you know what we're talking about now. And when we talk about developing these technologies in a responsible and ethical way, well, it does, every technology needs to be taken in account here, being websites, mobile apps, telehealth, or chatbots, virtual reality. We always need to think about these issues when we develop these technologies. So my interest began quite a while ago. I did this study where I compared in 2008 telepsychotherapy to psychotherapy in person for post-traumatic stress disorders. We did assess a lot of things. Of course, we assessed the efficacy in terms of reduction of symptoms, but as well as in the quality of therapeutic alliance as well. And just at that time, we did face some ethical issues because when we wanted to treat these people remotely in a city that was 2 hours ago from Montreal, Well, the ethical committee was disagreed that we do this treatment from their home. They said, no, 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 no. They need to go to a hospital in their city because they might get suicidal during one of the session, and if nobody's there to take care of them, well, they might commit suicide. Well, okay then. So we did that, and of course it complicated a bit the process, but finally we succeeded at recruiting over 60 patients for that research. What we found, it's equally efficacious, same quality of therapeutic alliance, and believe me, at that time in 2008. We did not have this Zoom or messenger video quality of image. It was a huge screen, and I remember that our therapists were kind of scared that the patients would not feel comfortable, because if they would cry, they told me that, well, if they cry, I won't be able to give them something to wipe their tears. I said, well, I don't know. And what we saw is that people brought their Kleenex box themselves, and they wiped their tears alone in their office in the hospital, 2 hours away from our office. So, but we also accompanied over the years other researchers who developed very innovative digital technologies, such as Janiul, who developed a self-management website before that she made that in a paper format, and then she translated that into a website. It's not easy. You don't just put PDF on a website. You need to rethink the way that you want the philosophy of your program to get to the people who need it. And I'm very proud to say that this was the first and so far the only digital tool that was adopted by the Ministry of Health and Social Services during the pandemic in the province of Quebec, and still is today. So, a very nice website. We also developed over the years several mobile apps, some for bullying during adolescence, depression and suicide in adulthood, as well as chronic stress. These three apps are available freely on the App Store and Google Play, both in French and English. And have been at least partially validated scientifically, so we are very confident that they can help people who will use them. Well, what about the mobile apps context? I'm going to talk to you more about mobile apps, because this is where the issues of ethic and responsible development have been addressed the most so far. You already know that there is a lot of mobile apps on these stores. More than 10,000 of them focused on mental health. And so, of course, how do we pick them between 10,000 mobile apps? How do a simple citizen, look at that? And can they rely on the number of stars, that is on the App Store or Google Play? Of course not. It's not an indicator of their appropriateness for their problem, right? So we need to develop for that assessment tools that will help people to be confident in the app that they will choose, and this assessment must be based on several standards, so that it's something that will be equal from one app to another. What we know so far is that many of these tools a few of them have been developed by great organizations, including the American Psychiatric Association. And what we know so far is that only and I could have wrote very, very, very small minority meets the minimal standards of quality, and including the minimal evidence of efficacy. We did a meta-analysis with my colleague Tania Lecomte a few years ago, and we did see that less than 5% of those 10,000 apps on the stores had been validated scientifically, at least minimally. So really, there's a lot that is offered, and we don't know exactly what it can do. And of course, it can have negative effects for sure. I know that there's a huge publication that was recently published in a great journal who mentioned that an app that was supposed to help to prevent suicide did exactly the opposite. So, as an example, I will show you the assessment criteria that the APA developed a few years ago. It's been updated very recently. It's also supervised by a person who's highly seen in the field. It's John Torres, who is the medical director of the Division of Digital Psychiatry at the Beth Israel Deaconess Medical Center of Harvard University. And so you see that there is a lot here of criteria that we should take in account when we select an app for a mental disorder. Of course, it's not easy even for a very experienced clinician to travel through that. So John made a video that I will show you only a few minutes of it. It's 9 minutes long, but we'll just look at 3 minutes. So, and he explained how we can use these assessment criteria when we look at an app. So is it going to start? Yeah.
Hello, I'm Dr. John Torres with the American Psychiatric Association's Committee on Mental Health Information Technology. Welcome to the third video in our three-part tutorial series about how to use the APA's app evaluation model. Hopefully, you've already viewed the first video in our series providing an overview of how to use our app evaluation model. If not, I recommend you take a few minutes right now to watch it before continuing on with this video. In this video, I will again be using our model to actually review an app so that you can see how easy and straightforward it can be to apply in your own clinical practice. The app that I'll be evaluating is called PTSD Coach. You can visit the app's preview page in various stores by clicking on the link in the references on this website. Let's start with level 1 of our model, which is collecting background information to understand where's the app coming from. One question in that level is, who is the app developer? Well, we can quickly see that this app has been released by the US Department of Veterans Affairs, or the VA. What's the cost? It's offered for free by the VA, so we do not see any apparent conflict of interest. The business model appears to be none, in that this app is a free service offered by the VA. We don't see any hidden costs or subscriptions that this app is offering. On what devices can this app work? We see that it works on both Apple and Android devices. We also note that the app recently updated. The goal of level 1 again is not to judge an app, but rather to formulate an understanding of where this app is coming from and the foundation upon which it is built. Now that we have this background information, we can move up to level 2. Level 2 is assessing privacy and security. We can quickly find the privacy policy, and reading it is a pleasant surprise in that we see that it's short and simple to follow. In essence, the VA says that it will never take personal data off the smartphone of the person using the app. However, some data may be transmitted for analytics, but the user has the option to turn off this feature in the app settings. Essentially, the app relies on you and your patient to protect their own data, and that data will be stored on the smartphone and not transmitted. As you probably are aware of, most privacy policies for apps are not this simple or favorable. Some language that you may want to look for when evaluating your own apps refers to a clause around data sharing. An app may look great in the privacy policy, but say that the app won't sell your data except if the company itself is sold, then the new buyer of the company determines what happens to all the data. So even what looks like a great privacy policy may not always be so great.
So I'll stop here, but you can see that it's not simple, and it's not with a few stars that we decide. So if you want yourself as clinicians to take, ethical and responsible decisions toward the kind of digital technology or mobile apps that you want to suggest or recommend to your patients, well, you need to, to get through these assessment criteria and to eventually be able to analyze what you recommend. I had the chance over the past 2 years also to be included in a committee that was put up by the Mental Health Commission of Canada to develop a new assessment framework for mental health apps. This exercise engaged just under 200 stakeholders spanning various roles and perspectives included, but not limited to, policy and research, persons with lived experience, patients, of course, providers, health executive, and app developers and app designers. So these people, these are exactly the kind of people that we wanted to gather and to reunite within our ecosystem. So this, I will show you a preliminary version of what it will look like, but it's not over yet. So far, I've counted this morning that there are over 150 criteria that were retained for this preliminary version. Of course, we will go through more further to reduce it, but still, you can see that it's complex. So a few examples of the dimensions. The first one is scene setters criteria. It aims to understand the application's core purpose and functionality. These include the target audience, the type of data the app collects, and the app's primary functions and features. So one kind of questions that it is asked as a criteria is, does the app include a symptom checker? And if yes, should we plan some action, like, of course, if the person reports that they have reports that he or she has suicidal ideation. Another important one, data and privacy standards. So we need to identify the relevant privacy policy for the app, which is available to users through the application and or the App Store or Play Store. And the policy needs to be as transparent as possible. So you need to look at that before to recommend an app to a patient. And if, for example, the user is informed of the developer's intentions with processing and sharing their data, then as John was telling earlier, if the company is sold, what will happen with the data that you shared with this company? That's very important. I believe that your patients will be very interested by that. Of course, these apps need to meet clinical evidence standards. I won't tell you what kind of evidence you know about randomized control trials, but with mobile apps, it's not the only way at all. There are stages that we can go through from more qualitative studies through eventually what we call micro randomized control trial. I could tell you a lot about it, but I see that I have no time left. With the other criteria that or standards that were retained in this preliminary version, we have clinical safety, usability and accessibility, security and then technical stability, cultural safety, social responsibility, and equity that also needs to be taken into account. So this kind of framework is the kind of tool that enable the researcher, the user, and the developer to talk together at the very first step of the development so that nothing is forgotten along the way. And finally, one thing that is very important, the principle of equity, diversity, and inclusion that needs to be taken in account again at the very beginning of the ideation. And so if we want to, we need to follow the 4 process requirements of innovation in a responsible way. So inclusion of diverse stakeholders, anticipation of risks, impacts, and unintended consequences, reflexivity about the norms and values underlying innovations, and finally, responsiveness to unforeseen and undesirable changes. As a very short conclusion, just as my friend Raymond told earlier, we're at the spring of of new technologies in mental health. We're at the crossroad, and we'll enter a new paradigm of care for sure, due to many factors. And I guess that we will need to agree on a framework and communicate about it, and so that we adopt it in a long way. So thank you very much for it.